So we're thinking now about the lungs and the lungs in childhood and the way they develop. Now, when a child is born, they'll have about 10 million of these alveolar air sacs that we're already familiar with. About 10 million of these. Interestingly, in you, there's probably 300 to 500 million of these. So 10 million in a neonate, 300 million to 500 million in you as a young fit adult. And in the neonate, these 10 million alveoli, if we open them all out, we end up with a space which is 3 square meters of internal surface area. This is the respiratory membrane. This is exactly 1 square meter. So the neonate has 3 square meters. 3 square meters. Now in you, you've probably got 70 to 100 square meters of internal alveolar surface area inside your lungs. And of that, 60 to 80 square meters will be in contact with the blood directly through what we call the respiratory membrane. So this is actually representing the respiratory membrane, with the blood on one side, the erythrocytes circulating on one side, the air coming in and out of the alveoli on the other side. In life, this is only 0.5 micrometers in diameter. It's a half of a micrometer in diameter. That's about a 15th of the diameter of a red blood cell. So very thin membrane to allow very rapid gaseous exchange, but giving this huge internal surface area. Now, most of the growth in the lungs takes place during the first year of life, from birth to the first year of life. There's an increase in the size of the alveoli, but primarily there is an increase in the number of the alveoli. This is a process called neo-alveolarization, where there is a proliferation in the number of alveoli, getting up towards the adult level as childhood goes on. So there is increase in size of the alveoli, but there's many more alveoli are developed in neo-alveolarization. And as well as that, the respiratory bronchioles that connect the alveolar air sacs to the larger bronchioles, they're going to increase in number as well. And the most rapid increase is in the first year of life, as we've said, but also through to about 8 years of age. So at about 8 years of age, there's nearly, alveolarization is nearly complete at that stage. But it will go on right all the way through to adolescence. There's some increase in the number of alveoli. And this brings out a really important point. Now, the major airways in the lungs, the major bronchial tree, that is complete from about 16 weeks gestation. So after birth, there's growth in the number of alveoli, increasing the number of alveoli in the smaller airway passages, but the larger airways are complete by about 16 weeks gestation. But if the mother is exposed to tobacco smoke or to other pollutants during that phase, in this first critical 16 weeks, then that can affect the overall development of the lungs. And if that window of opportunity is missed, then the anatomical architecture of the lungs can never be restored forever for the rest of that child's life and what becomes that adult's life and eventually that old person's life. It will never be restored and they'll have reduced lung function for all of their lives. And as well as that, during the first two years of life, certainly, but up to 4 or 5 years of age, then if that child is exposed to airborne pollutants or tobacco smoke, then that also will affect the ongoing development of the smaller airways and the alveoli. And again, if that window of opportunity in early childhood is lost, it can never be regained. That person will have defective lung anatomy and architecture for the rest of their lives, and consequently reduced lung function for the rest of their lives. And this is very consistent with the idea of the first 1,000 days that are so important, that there's critical windows of development, and if those windows of development are missed, then the adult can never catch up, or the older child can never catch up with those windows of opportunity. So there you go. In your lungs at the moment you've got 70 to 100 square metres of alveolar surface area. But remember, the neonate only has 3 square metres of internal surface area. So when you need to breathe in, your diaphragm goes down the way it flattens. Your ribs move up and out as the external intercostal muscles pull the chest wall up and out. And in you, at the moment during quiet breathing, about 75% of the volume change in the thorax is generated by movement of the diaphragm. But in neonates, it's nearly all generated by movement of the diaphragm. The diaphragm goes down. And when the diaphragm goes down and the ribs go up and out in you or in the child, that is going to increase the volume of the chest. It's going to increase intrathoracic volume. That is going to reduce the pressure, meaning the pressure inside the chest is lower than the pressure in the atmospheric air outside. So air is sucked in to equalise the pressure. We are negative pressure ventilators. But the diaphragm is made up of skeletal muscle. It's primarily skeletal muscle. And there are basically 2 types of fibre in skeletal muscle. There's type 1 fibres, which are slow twitch, slow contracting fibres. And there are type 2 fibres, which are fast twitch or fast contracting fibres. And in you, as an adult, about 55% of your muscle fibres in your diaphragm are the slow type, the slow contracting type 1 fibres. And that's good because these contract slowly, but they have a very high aerobic capacity. They can go on for a long period of time. So obviously a diaphragm goes on for your whole life, but if you want to increase your workload, then these fibres can keep contracting for a long period of time. And they won't get too tired, even if you want to climb a mountain or run for a long distance or cycle a long distance, they'll keep going. But then if you want to sprint and do something really fast and really energetic where you've got to greatly increase your ventilatory volumes all of a sudden, then your type 2 fast twitch fibres will kick in. And you've got about 45% of these in your diaphragm. About 45% of yours are the fast type of fibres. And that means that you can greatly increase your ventilatory volumes if you want to exercise. So that's good for a period of time. But the reason you can keep going for long periods of time is because 55% of the fibres in your diaphragm are these type 1 slow fibres. But with a neonate, it's not like that. When neonates are born, they have slow fibres, but only about 25% of their fibres are the type 1 slow fibres. That means 75% of their fibres are the fast twitch fibres. And of course the fast twitch fibres aren't as aerobic and they tire more quickly. So children cannot make an increased ventilatory effort for long periods of time. They get tired very quickly. And this is why it's dangerous if children have obstructive conditions in the chest, for example, which mean they have an increased respiratory effort, they have an increased workload in their diaphragm, because their diaphragms will tire, because only 25% of their muscle fibres are the slow type 1 fibres, so they can tire very quickly. And of course, tragically, that can lead to respiratory failure. Now, this proportion does change fairly quickly. So by the time the child's around about 2 years of age, then they've got more or less an adult proportion of the type 1 slow fibres and they've got more respiratory reserve. But for those first 2 years of life, when the type 2 fast fibres predominate, they get tired very quickly. Now, just to introduce the next clip of this video, I want to talk about connective tissues. Now, what is the main connective tissue in the body? Well, you probably know that the main connective tissue in the body is collagen. It's a tough connective tissue. Now, when a neonate is born, there's lots of type 3 and type 4 collagen in the lungs. And this is much more pliable, much more elastic than the type 1 collagen fibres. So fairly quickly, the type 1 collagen fibres start proliferating. So by the time the child is 1 or 2, and certainly in older children and in you, there's a lot of type 1, much tougher collagen. But it's good to remember that in the neonate, and even more so in premature babies, there's a lot of the type 3 and type 4 collagen fibres, which aren't as mechanically strong as the type 1 fibres that we get in older children. And this makes the lungs more elastic and more compliant. And the reason for this is, when the child is born, the lung is still developing. In the later stages of pregnancy and early life, the lung is still developing. So if we had rigid collagen in the lung, then that could impede the cellular migration which generates the new architecture of the lung. So to facilitate this process during fetal life and very early infant life, up to about a year of age, there's more type 3 and type 4 collagen, so the lung is more compliant. But more of that in the next clip. Now this diagram shows cross-sections of the chest at various stages of life. And the black line here is birth. So that is the cross-section of the chest at birth. The green line is at 3 months of age. The red line is at 3.5 years. And the blue line is the adult cross-section of the chest. Now, clearly there's an increase in size, an increase in volume. That's going to be fairly obvious. But as well as that, we see that there's this reduction in depth and the chest becomes broader. And that's important because it allows for greater adjustment of the volume of the chest with movement of the chest wall, with the movement of the ribs and intercostal muscles. Whereas with the younger child, movement of the chest wall will have less effect on the overall volume of the chest, explaining partly why children rely on diaphragmatic breathing so heavily at birth. But we can see that that becomes less by 3 months, less by 3.5 years, and of course the picture in the adult is completely different. Now the next thing I want to talk about is the idea of compliance that we've been talking about. So here we have a diagram of the chest that you're probably vaguely familiar with, and we have the airway, the main airway, the trachea, the left main bronchus, right main bronchus, lung. I've only drawn 6 ribs here. These are the ribs here in black. The intercostal muscles between, and of course the diaphragm at the base. Now let's think what we mean by this term compliance. What do we mean by compliance? Well, compliance describes the amount of effort needed to stretch the lungs and the chest wall. High compliance means the chest wall and lungs will stretch easily, allowing for filling of the lungs with minimal effort. So if the balloon is easy to blow up, then that is a high compliance. It's easy to blow up. The lungs stretch readily and easily to fill with air. Conversely, low compliance means there is resistance to stretching. So it's much harder to blow the balloon up. It's much harder to inflate the lungs. And this results in more effort being required to inflate the lungs. And over the first few weeks of life, compliance will increase as fluid is drained from the lungs. So the fluid which is naturally present in the lungs at birth will drain. That will make it easier for the lungs to inflate, and that will increase compliance. And another major factor is lack of surfactant in premature infants is going to increase the surface tension. And if you increase the surface tension, you're going to decrease compliance, because this surface tension is a cause of impedance to lung function. And we can see what we mean with the analogy we've used before when we thought about the pleural membranes of two separate acetates. So here we have a couple of acetates, and it's moist between them, and the moisture generates surface tension, and that's going to hold them together. So even though I'm not holding this one, it's come off now, that's fine. Even though I'm not holding that one, it will still go up. It will still go up and down. It would have had a bit more water on it. Put a bit more water on it. There we go. So you can see the way the water spreads out there, generating surface tension. Sticking the two acetates together. So you can see they're like stuck together there. There's this sticking effect generated by the surface tension. Now this is analogous to the alveoli. So in the alveoli, because they're so small, when the child breathes out, these can come together. The microscopic air passages can come together. And if there's surface tension between the two, then they're going to stick together and we're going to get atelectasis, we're going to get claps. So what the surface tension does is hold these two sides of the alveoli together. And there's actually resistance to them. They're sticking now, look. There's actually resistance to them coming apart. Which of course is the last thing we want, because it means the air can't get in. So what the surface tension does is hold it together. What the surfactant does, it's a detergent-like substance and it reduces the surface tension. So even if they do happen to come together like that, then they're not going to stick and the lung's going to inflate much more easily. And if the lung inflates more easily, that is going to increase. That's going to increase the compliance, making the lung easier to inflate. So if we go back to this diagram here, this was our chest wall and lungs. So young children have a compliant chest wall as well. The chest wall is flexible. And this is partly due to the chest wall containing a lot of cartilage and the ribs being poorly ossified. So the ribs still have a degree of rigidity, but it's much less than in the ossified older ribs. And the intercostal muscles are also thinner, less well developed, therefore they're more compliant and flexible as well. And this high chest wall compliance is even more pronounced in premature babies. And it's the high chest wall compliance that leads to sternal recession, when we observe for this rib spacing in drawing and this supraclavicular space recession, when there is airway obstruction or a decrease in lung compliance. And this indrawing effect is sometimes called paradoxical breathing. So what normally happens is we get movement of the chest wall up and out, and we get movement of the diaphragm down. That's going to increase the volume of the thorax. Of course, as we increase the volume, that's going to decrease the pressure in the lungs. There's a decrease in pressure. And it's that normally sucks the air in, because the atmospheric pressure outside is still 760 millimeters of mercury. It's normal atmospheric pressure. But the pressure in the lungs is now less, so the air is sucked in, because of course we are negative pressure ventilators, sucking the air in. But if there's obstruction to the airways, especially at the level of the smaller airways, the bronchioles, in bronchiolitis for example, if there's obstruction to the airways, then the air can't get in as easily. So the air can't get in to equalise the pressure. But the pressure in here is still reduced. So if the pressure in here is reduced, but the air can't get in to equalise the pressure, then what happens is that the chest wall tends to be sucked in, and we get this paradoxical movement. Now we know the ribs are poorly ossified, but they're still more rigid than the intercostal spaces. So we see this particularly at the intercostal spaces. So the volume has increased. The pressure is therefore reduced. It's not being quickly equalised because of the airway, relative airway obstruction. So these get sucked in like this. And we see this intercostal recession. It's a simple matter of suction because of the reduced pressure within the thoracic cavity generated by the upward movement of the ribs. So when the ribs and chest wall are supposed to be moving up and out, we see the intercostal spaces particularly moving in, and that's what we mean by this paradoxical movement. Another application of the chest wall being compliant in children means that any chest trauma is unlikely to cause rib fractures because the ribs are flexible. And this means a child can suffer quite severe parenchymal injury without rib fractures. So a child can be quite badly injured but not have fractures, so it's just something to bear in mind. So infants and young children have small airways compared to adults, and these can quickly develop into clinically significant airway obstruction. Because remember, when we reduce the diameter of the airway by a little bit, we increase the resistance to the airflow by a lot. And if we increase the resistance to the airflow, that's going to decrease compliance. Now, I think I'll just say something else about this surfactant just before we finish, because it's pretty amazing stuff. This surface active agent that reduces the surface tension and prevents the sticking together, prevents the atelectasis. It's actually produced by the type 2 pneumocytes, and it's a complex combination of different types of phospholipids mixed with protein and neutral lipids. And these neutral lipids are important because they're hydrophobic. They're hydrophobic. They don't like the water. They're hydrophobic molecules. So a hydrophilic molecule would stick together. A hydrophobic would repel. It repels. And this is because these neutral lipids are lacking electrically charged components of the molecule, so they don't have attractive electrical charges to stick to the water molecules, because of course water is a polarized molecule. So without the surfactant, surface tension in the alveoli is very high. The average diameter of the alveolar air sacs is less than 200 micrometers, so they're absolutely tiny little air sacs with the respiratory bronchioles and the alveoli. Very, very small, microscopic little air sacs. So it's the detergent-like properties of the surfactant that greatly reduces the surface tension, thereby increasing lung compliance, making the lung much, much easier to inflate, preventing the atelectasis, allowing for easy inflation of the alveoli, preventing it sticking together after expiration.